sharing your screen. Let me know if any issues.
So again, principally focused on pulse oximetry and tissue oximetry, and developed within the area of clinical study design and statistical models. He's part of the ISO committee member and working on international standards and clinical evidence requirements for pulse oximeters. So hopefully he's got control of the screen. It looks like it's working. Now, I find statistics quite interesting. When I want to put a patient to sleep, I get out the tax code. If I want to find something really boring, not statistics.
Sandy, you taking notes now? Yeah, back.
Yeah, you have to speak up a little bit, but
Okay.
you're good.
All right, I had to stop taking notes here for Sandy. Okay, so got to follow Gene here, who I spent quite a few months now, probably the past year or so, working with Gene on what he does. So before we get to statistics, working for Medtronic here. This is the reason I'm here, why probably all of us are here, and beginning with our Medtronic mission, really compels us to alleviate pain, restore health, extend life. Really defines who we are and our commitment to the patients and clinicians relying on this technology. So as a leader in the pulse oximetry field, we're partnering with regulators, academics, clinicians, and others to achieve equitable health care for all patients. We've been currently evaluating and continuously improving the performance of our pulse oximeters since introducing these devices more than 40 years ago. Some of our most recent development activities, we've included up to 40% enrollees with dark skin pigmentation to ensure our technology will perform as intended for all our patient populations. We stand by with the FDA, our customers, and patients to better understand the discrepancies we've all talked about today and eliminate any health disparities. Right here, this is really a summary of why we're all here this week. The significant increase in review of pulse oximeter clinical performance, the recent FDA advisory committee in November 2021, all demonstrated this call to action and dedication we at Medtronic and this global open oximetry community have to researching the effect of dark pigmentation and SpO2 accuracy. And this summarizes, the incredible increase in recent literature, FDA engagements over the past couple of years, and Medtronic's public acknowledgement and statements to these new issues. So inequity occurs when subtle differences add up. I think this is something we've been talking about all day today. And these are all the factors that affect measurements and the ability to estimate oxygen saturation using the pulse oximeter. So rebuilding the confidence in the technology and the clinical use, which provided such clinical benefit over the years, is our position here today. The perception issue from the recent review of real-world clinical use cases in both technology development as well as the education that can be provided right now is critical to advancing equitable healthcare. So more work, we understand, certainly needs to be done, and we continue to stand by our partnerships, collaborating with FDA, ISO, Open Oximetry, clinicians, further understanding all these confounding variables to SpO2 accuracy, foster health equity by improving standards for development of pulse oximeters. And really, this is what we've been talking about today. We have the base technology performance of the oximeters, sensor selection and position, patient perfusion, patient skin pigmentation levels. And we all are invested in improving our algorithms, clinical innovations across the portfolio. So as I said, we spent probably the better part of the year working with Gene and reviewing all of his models. And this right here is all of the key issues where Medtronic has chosen to put our best efforts in researching solutions and aligning with proposals discussed in this forum. So we do support decreasing the accuracy acceptance limit This would be aligning ISO with the current FDA guidance, recommending less than or equal to 3% accuracy in terms of root mean square for transmittance graph finger clip sensor types. I think Sandy presented earlier, the ISO standard currently now is at 4%, differing from more accurate requirements by the FDA. Increasing the precision of the pulse oximeter with a decrease in the minimum acceptable limit to 3% provides a reasonable balance of maintaining a high accuracy with its acceptable minimum threshold, innovations in technology for its best case accuracy determination under these ideal conditions in a controlled lab setting. We do support conventional study design, as Jean brought up the two different models. The gold standard reference for SaO2 from Pulse Oximetry to determine oxygen saturation. We believe that traditional hypoxia desaturation evidence collected with this arterial blood sample represents the optimal method for accuracy determination. Secondary standards, transfer standard or silver standard, for a medical grade oximeter verification needs more internal review of large empirical data sets at this time to deviate from the gold standard of blood oxygen reference. And this is something we have been beginning to actively investigate along with Jean's models that he's been presenting and with Paul Batchelder. So we support objective measure of skin pigmentation. I think this will be discussed in my following slide, but for a standardized method of pigmentation classification. Support increasing controlled healthy subject hypoxia sample size with statistically powered subgroup for pigmentation. So a larger sample size, as we've heard, will allow the statistical comparison of subgroups while decreasing the confidence interval of the accuracy estimate, whether it's RMSD or mean bias, and the ability to discriminate differences in these subgroups. And we support the further examination of additional proposed statistical analysis models of clinical study data, which we just heard from Jean. So internal review has been underway for several months with these additional models proposed by Jean and the FDA. There have been proposed statistical clarification of device performance, in addition to the required RMSD accuracy, simple linear regression of SpO2 on SaO2, Bland Altman, which deserve our consideration. The modeling of internal data will continue as more defined set of clinically significant saturation ranges, subgroup differences to detect, and clinical confounders to define and propose for both statistical evaluation and clinical designs. So I think this is really where we need to get to this week, is coming to consensus and understanding the inputs to all the models that are being proposed that will all balance out sample sizes and the appropriate models to present performance of the device. So on skin pigment classification, we believe the objective measure for melanin and subgroup classification correlation is the preferred method. And we've done this correlating it to the subjective models, Fitzpatrick and the Massey score, just from internal data. So the colorimeter using the Delphin melanin values have appeared to have a strong linear relationship to subjective ratings. The objective measurement for melanin allows for more precise parsing of data in subgroups compared to a discrete scale, as it does not have the same limitations of fixed intervals as a subjective scale. So melanin can vary significantly from individual to individual, regardless of the shared race and ethnicity, as we've heard. Melanin absorbs certain types of light and may affect the accuracy of pulse oximeters. So understanding a standardized method for classifying pigmentation needs to be developed, which does not exist now. And we need a uniform method of assessing pigmentation and the appropriate representation in clinical verification trials. These statements and the conclusions we made here with the correlation to these subjective scales are not to support Fitzpatrick or other subjective pigmentation, but to confirm this correlation to past data and clinical evaluation of skin pigmentation subgroups, and to understand the optimal method going forward in objective measure of melanin, which we believe is the preferred method. So looking at, everything that Gene has provided and through the data analyses, I do believe the proposed ANCOVA sample size model and the inclusion of the covariate analysis by the FDA has been reviewed to internal data. Further investigations of the inputs, like I said, are in process. But consensus on the clinically significant difference of bias in group allocation of samples between pigmentation subgroups is required as well. Adjustments for repeated measures within subject variance via COVA extend the model to dependent data in clinical study design. So we do believe these improve statistical power and ability to differentiate subgroups with an increase in study sample size and improve statistical interpretation of data will aid design and demonstration of performance for high quality pulse oximeters. So we do believe that more is needed. And I believe that most of what Gene has been presenting deserves consideration and understanding how we properly implement the descriptive statistics and models to present performance of the oximeters. So reviewing all these simulations and laboratory data provided by Gene for the conventional design, increasing data eventually reaches that inflection point to produce a better performing oximeter from a much larger clinical subject population. And significance and statistical power of subgroup analyses by decreasing the confidence interval in the estimate of the mean bias, the SpO2 minus the SaO2, precision, and root mean square difference. The effective sample size should be considered this week, gaining consensus on the inputs to the models, including pigmentation subgroup sample size, number of groups, allocation of bias, and balance all the factors involved in executing a controlled laboratory hypothesis study. And we do look forward to continuing this week, this open discussion, and coming to agreement on these decisions. Really, as I conclude, we're using our partnerships to include everybody here, the FDA, the ISO organization, clinicians, to reach and scale to expand health equity. This is our greatest commitment we can make, is to consistently positively influence health outcomes for all patients. And health equity is foundational to our Medtronic mission. So I do want to thank everyone for the opportunity to share our perspective today. I'm hoping that by the end of this week, we can come to consensus and propose some new requirements and guidance.
All right. Thanks, David, very much. We have one more brief session this afternoon with two presentations, and then we're going to come back and have discussion. I think there's a lot probably to discuss from the last two presentations that we heard, so save your questions for that. And we will be back to that probably in about 20 minutes or so. So Dr. Hendrickson, over to you.
All right, I'm moderating an open forum, and we have two speakers who are going to present, Zach Vesoulis and Francois Lellouche. Unfortunately, Dr. Kumsen was unable to make this part of the meeting. So I'm going to ask if Dr. Vesoulis would start screen sharing and get ready to present while I give your introduction. So Dr. Vesoulis is a neonatologist and assistant professor of pediatrics at Washington University. His research is focused on the use of multimodal monitoring devices, including conventional and optical monitoring, to understand physiologic mechanisms of neonatal brain injury risk and to develop targeted, informed interventions. Streams in cerebral and systemic oxygenation play a major role in neonatal cerebral pathology. Thus, the impact of racial disparities on oximeter accuracy play an outsized role in clinical care. With that, I will turn it over to you.
All right, thank you so much. I really appreciate the opportunity to speak today. I'm going to be addressing a little bit of a different population. It's an important subgroup, and hopefully I can provide some context that really drives home how all the things that we've been discussing today might matter even more for this patient group. So how are babies different? We've talked a lot about adults today, and there are really four big areas that I think distinguish babies, especially preterm infants, and how they interact with the pulse oximeter. So the first is their hemoglobin. Babies are born with predominantly fetal hemoglobin subtype. This transitions over a period of months towards hemoglobin A, but that really varies. We draw a lot of blood out of the babies that we take care of in the ICU. They receive blood transfusions. So the proportion of hemoglobin F and hemoglobin A is variable across this population, which of course influences their oxygen saturations. Respiratory support is very common. Respiratory failure is actually the most common diagnosis that we deal with in the NICU, and babies regularly receive support of some sort, usually with supplemental oxygen for 6, 8, 10 weeks or more in some cases. The excessive supplemental oxygen is associated with a lot of bad outcomes. Retinopathy of prematurity is the most common acquired cause of blindness in childhood. Excess oxygen exposure is associated with chronic lung disease, or also called BPD sometimes. Hyperoxia is associated with worse neurodevelopmental outcomes independently, as well as hypoxia, which also is associated with all 3 forms of preterm brain injury, including intraventricular hemorrhage, cerebellar hemorrhage, and white matter injury. And the other thing that's very different, the patient population that we're dealing with, they're still developing. They were born 3 or 4 months early. And the processes that normally go on in utero are now part of our regular clinical care. And certainly melanocytes are present, but the production of melanin really doesn't happen until babies are about 32 weeks corrected, or at least that's where we can pick it up in things like skin reflectance measurements. But we take care of babies all the way down to 22 weeks. So the role of melanin in interfering with pulse oximeter accuracy may be less of a factor, or maybe an uncertain factor. Hypoxia is very common in this patient population. Like I mentioned, all these babies have immature lung function and immature control of breathing. So babies are apneic all the time. They desaturate all the time in the NICU. And then there's 2 figures here. One is from a paper that our collaborative published a couple of years ago, looking at the number of desaturation events per day. And 40, 50, 60 events per day is not unheard of at all. This is very different than an adult ICU population. This is, I guess, what you would call routine apnea, in a sense, that it's something that we deal with all the time in babies that are not necessarily even sick. This is just part of their normal physiology. We also pick this up in the brain. So over on the right, this is a NIRS measure, a different optical device, but using a lot of the same principles. And we pick up intermittent cerebral hypoxia. And this is influenced by existing brain injury. That's the difference between the red and blue lines here. But babies have 50 to 100 intermittent cerebral hypoxia episodes per day. And about half of those we've found are not even associated with systemic desaturation. So these are isolated cerebral desaturation events that are being picked up by optical devices. There's a very strong link between hypoxia and brain injury, as I've mentioned. All 3 forms are common. On the left figure here, this is a fractional oxygen extraction measured using pulse oximetry and NIRS for babies who developed white matter injury on term equivalent MRI, which is the black line here, compared to babies who did not. And you can see that oxygen extraction rises as these babies become anemic. They extract a greater proportion of the oxygen in their blood. But babies who have white matter injury extract more oxygen out of the blood the entire time they're there, approaching nearly 50% oxygen extraction, which is an extraordinarily high amount and exposes especially the areas of poor perfusion in the brain to ischemia. Also, just with a pulse oximeter, we don't even need a NIRS monitor to pick it up. For babies with severe intracranial hemorrhage, we see a remarkably higher increase in the amount of hypoxia in these babies. There's 0.1% of the recording for babies that don't have severe bleeds versus 3% of the recording over the first 3 days after they're born. So Pulse Ox, hopefully everyone is convinced that hypoxia is important in the preterm population and something that we deal with frequently. This also really drives home why accuracy of the pulse oximeter is so important. We use oxygen a lot, and it's an important life-saving drug. As I mentioned, ROP, or retinopathy of prematurity, is a complication of using too much supplemental oxygen. There was an explosion of it in the 1950s when people started figuring out some of the early forms of respiratory support. The response to that was to limit the FiO2, the amount of oxygen we're delivering, to 50%, but that was associated with an increased risk of death for every case of blindness. There was a whole series of randomized trials that occurred after that, and a widely accepted standard that emerged in the 90s, really late 90s and into early 2000s, was a targeted range of 85 to 95%, which I know sounds strange to those of you who normally take care of adults, but this is what we thought was the best balance of increased risk of death on the lower end of the saturation spectrum versus increased risk of ROP on the high end of the spectrum. There was a landmark clinical trial that was done by the support group led by Wally Carlo, who utilized Masimo Pulse Oximeter, which had altered software in it to intentionally put babies in either the low end of this accepted range, so the 85 to 89%, versus the 91 to 95% range. At the time the study was done, we thought these groups were equivalent, and we could perhaps decrease ROP in this lower saturation group without increasing the risk of death. Even though the design of the pulse oximeters was set to put the median SpO2 in the two groups fairly far apart, they didn't really wind up that far apart. It was only 91 versus 94% for the median SpO2. However, there was a remarkable difference in mortality between the two groups, 16% versus 23%. You can see some figures from that paper here, including the distribution of oxygen saturations in the two groups, which were not really that far apart from one another. But that's why inaccuracy is so important. There's such a small difference between those two groups, yet such a large difference in their mortality. A study we did that some of you may be familiar with, we used Dr. Schroding's method where we compared SaO2 to SpO2 pairs in a real patient population of preterm babies, all less than 32 weeks. And we found that on average, there was an overestimation of SpO2 in Black infants by about 1.7%. But coming out of the support trial era, everyone has changed to a much narrower targeted oxygen saturation range of 90 to 95%. But if the error in one of our subgroup populations is 1.73%, that's more than the third of our target window. This is a figure from that paper. The black line represents the Black infants. The dotted line represents the white infants. You can see there's a consistent gap in measurement bias over the entire pulse ox range, although it's not actually a linear relationship. It increases as SpO2 decreases. This is a project that we've done recently that's still unpublished, where we looked at not only SpO2 between Black and white infants, but also the amount of supplemental oxygen that they got. This was 126 Black and white infants that were matched on gestational age, and we calculated the SF ratio, the saturation to FiO2 ratio. And we found that even though the pulse ox values that were measured or charted in the electronic medical record were very similar, the Black infants were exposed to more oxygen, which meant that they had a lower SF ratio. So trying to connect the dots here with what we found previously on validation studies, we're wondering if perhaps these Black infants have overestimation of their pulse oximetry that leads to increased occult hypoxemia, which eventually becomes overt hypoxemia. At some point, the babies can't compensate anymore and generates more hypoxic episodes, more bradycardia associated with it, and more supplemental oxygen as a result. This is still very speculative at this point, but there is definitely a gap here. One other technology I'm going to touch on just briefly is NIRS, which of course I'm sure as many or all of you know uses very similar optical principles, although is not pulse synchronized and interacts with all the different blood compartments. That's really unclear if the same sort of gap applies to NIRS, at least in the infant spectrum. One area where that's a lot different is that almost all the NIRS monitoring, especially in the neonatal world, is done on the head, which avoids a lot of the perfusion problems that we've talked about so far today. Since it's not pulse synchronized, that may influence the artifact issues. And then it's using different wavelengths of light. Some of the manufacturers use 5 wavelengths of light, some use 2, but they're different wavelengths, and they may interact with melanin differently. And cause less of an issue there. I did a fairly thorough review of the literature, and I could really only find 3 papers that addressed race-based differences in NIRS performance. And 2 of the 3 found essentially no difference. And then the third one found significant difference, but it depended on which device you were using. One of the devices in that study had almost no difference. The other one had a medium difference, and the third had a big difference. One of the challenges with validation in a NIRS model, however, is what do we use as the reference standard? Certainly a jugular bulb would be the gold standard, but that is extremely limiting in terms of who we're able to test the device against. We certainly are not going to put a 450 gram, 22-week infant into the cath lab and do a jugular bulb test for them. We could potentially use mixed venous saturation, but this is still unclear in this population. So just to sort of wrap things up, our babies that we take care of in the NICU have very unique developmental characteristics that are different than adults. They're also at the same time more vulnerable to both hypoxia and hyperoxia. They have distinct pathologic outcomes related to those extremes. We see a bias in overestimation of oxygen saturation as has been found in adult studies, and that leads to a difference in oxygen exposure. It's really unclear how melanin plays a role in this population because it's not present, at least not in the same concentration as it is in adults. Perhaps there's a difference in noise, in the signal aspect of noise. There may be perfusion differences or perhaps differences in autonomic or cardiovascular function that are at play here. And then, of course, NIRS is very much an open field. And that's all the slides I had. Hopefully didn't go too fast.
I have one question, but I also want to call attention to the chat where Rob is asking if you could weigh in on your experience with multiple pulse oximeters on the same baby. That sounds like a hard puzzle.
Yes. Yes, that's a great question. We do that fairly frequently in the NICU, which is another quirky thing that we do that probably seems sort of crazy to people who don't take care of babies. But our babies have lots of shunts. That's a shunt through the ductus arteriosus is very common, and we can get an indirect measure of how much shunting is going on by looking at a pre and post ductal saturation. But babies, even without shunts, when we put them on, we see a difference between the two. And it's often things that don't really make sense physiologically, why a postductal saturation would be higher than a preductal saturation, for example, in a baby that doesn't have transposition of the great vessels. It's definitely a difference that we see, and it may be perfusion differences between those two limbs. It could be a difference in the software. One of the pulse oximeters is running on the OEM chip that's built into the NPM. The other one is using a module that's inside. They might have slightly different firmware versions in them. We definitely see differences between the two.
And then please forgive this question to an adult doctor. But so if I followed correctly, you do not think that the babies have much difference in the melanin pigment in their skin, and yet you see this big difference in race categories, and we've been careful today to disentangle race from skin pigment. Mm-hmm. So does this not support that a pregnant person who is Black, assuming that the pregnant parent is the Black parent, is maybe experiencing different treatment, different health during pregnancy, and it's in utero exposure that you're detecting now postnatally? Or how do you explain that finding?
Yeah, that's a good question, and I don't know that I have an explanation for it, but I have some speculation for it. So melanocytes are definitely present even in the first trimester, so they can be seen. The melanin production can't be picked up, at least by technical means, until babies are about 32 weeks, which is a fairly sizable portion of our population that we take care of is below that age, and all of the babies in that study that I presented. Now, that doesn't mean that the amount that's not detectable by another measure may not still influence the pulse oximeter, but it seems like those two things would go together. But you're absolutely right that the influence of the prenatal or antenatal environment absolutely carries over to the fetus. There is a concept referred to as toxic stress in pregnancy that can be related to poverty, to pollution, to drugs, to stress from violence. All of these things affect the fetus in ways that we don't necessarily have a good way of quantifying right now, but are associated with worse outcomes. One of the pervasive inequalities that we deal with in the NICU is this idea that it is white males that have the worst phenotype, that do worse in terms of their pulmonary outcomes, for example. But when we actually dive in more deeply in the data, it's actually the Black infants, particularly preterm Black infants, that have much higher and under-recognized mortality, much of which is driven by poverty.
Thank you. That makes a lot of sense in the context of popular reporting about our shameful healthcare system and the outcomes for Black pregnant people and their infants. Okay, so thank you so much. I'm going to move to our next speaker and then leave a little bit of time for discussion as well. I want to invite Francois Lellouche to please share your slides. Dr. Lellouche is a critical care physician at Quebec Heart and Lung University and full professor in the Department of Medicine at Laval University. He's medical director of the H2O2CO2 lab. I'd love to hear more about that. And he has a program of research on optimization of oxygen delivery and evaluation of oximeters.
Okay, thank you. Thank you, Karen. Thank you, Michael, for the invitation to share our recent data on this issue. And there was a question in the chat about the relevance, clinical relevance on this small difference, error, bias, discrepancy between oximeters. And I will show you the impact on flow use related to this difference in SpO2 measurement, but also what is even more important, the impact of the discrepancy on SpO2 target recommendation. We will discuss there was a real difference in these recommendations. So we recently published a letter in the CHEST journal about this new concept of oxygen-free days, which was proposed by a group of New York, by Dr. Moskowitz and co-authors, to evaluate patient outcome in large randomized controlled trial. And we discussed the confounders of these oxygen-free days, and especially the impact of SpO2 target, as I will discuss, because you know that there is a lot of different recommendations in the literature. We also know that there is some potential impact of skin pigmentation, as this was discussed today, and we do not have currently all the data available, especially in patient. We have a lot of data available in healthy subject, but not in patient, but there is probably an impact of at least 2 or 3%. And finally, we also discuss the impact of the oximeter, because we recently published a study conducted in patients, in almost 200 patients, showing that there is a discrepancies between oximeters, which can go up to 4% when we compare two oximeters. And this all have an impact on oxygen flow, and this is what we will discuss. So you know that for COPD patients, the international guidelines recommendation are quite homogeneous, as almost all recommend to keep the patient between 88 and 92%. But for patients with acute hypoxemia, there are some very different targets. You know that the Canadian group recommended 92 plus or minus 2%. There was also some recommendation to stay between 92 to 96, and finally the US and UK recommendation were recommended to maintain the patient at 86%. So our question was to know what is the impact of 4% difference for the SpO2 target on oxygen flow in the patient. So we conducted a very simple study to titrate oxygen flow for different level of oxygenation between 90 and 96%. And we included all the patients in our institution. There were 36 patients who were on oxygen through nasal cannula, and the initial oxygen flow was 2.8 liters per minute. And as you can see, and as expected, it's very easy to understand, the more you want oxygenation level, the more you need oxygen. And what was interesting for us was to quantify the impact of the target, because it was very strange, but there was no such data in the literature. As you can see that just for 2% difference between 90 and 92%, the oxygen flow increase was twofold. And for 4% difference, we had to increase the oxygen flow by a factor of 3.5. And this is quite relevant for clinicians to increase flow by 3.5. So the other recent data that we have is a combination of the SpO2 target and the oximeter, pulse oximeter discrepancy. So we used in this study 2 oximeters that we previously evaluated. And you remember that the difference between those 2 oximeters was 4%. And we also evaluated 2 SpO2 targets. So we had 4 periods with oximeter A, we had 90 and 94%, and with oximeter B, 90 and 94%. And all the patients, it was a randomized crossover design. So all the patients were their own control to reduce the bias. So during 10 minutes, we tried to get 90% saturation with oximeter A and 94 with oximeter A, and the same with oximeter B, and it was in a randomized order. And at the end of each period, we recorded the oxygen flow and arterial blood gases. So these are the preliminary results based on 15 patients in post-cardiac surgery, and 100 of those patients were with light skin pigmentation, which reflects our local population. So you can see that with 90% SpO2 target, and the ratio of oxygen was 3.5, which corresponds with what we saw previously with different SpO2 target. But here, this is the same target, but with different oximeters. And this, again, is a quite important difference in oxygen use. Similarly, for the SpO2 target of 94% with the same 2 oximeters, the oxygen ratio was a little bit lower than 3. Again, it's a significant difference. And when you compare all this period, when you have 4% difference in SpO2 target and 4% difference in oximeters, you can see that there is a real impact on patient. In one case, the patient is near hospital discharge, and in the other case, the patient may be, there may be discussion to increase the level of respiratory support. But clearly, I cannot show all the results here, but in this situation, the patient also is more at risk of occult hypoxemia. So this is a trade-off between occult hypoxemia and higher level of oxygen flow. So in conclusion, it's clear that the discussion we have today has a real relevant clinical impact, and pulse oximetry differences and SpO2 target differences, which is a real issue currently, and the combination of both have major impact on oxygen use. So, as I said, 3.5 difference on oxygen flow just related to 4% difference in SpO2 target, and also in SpO2 measurements. And the combination of both have even more clinical relevance. And I could not here in our institution evaluate the impact above this, the impact of skin pigmentation, but probably it increase again the differences. So I think in the next discussion we will have about SpO2 target recommendation. We will have to take into account all these differences in oximeters, brand, and skin pigmentation, and it will not be possible to use a recommendation for all patients, whatever their situation. So this is my last slide. Thank you.
Dr. Lellouche, thank you so much for the presentation. It's such an interesting design that has clear and tangible clinical impacts for both inpatients, but also outpatient patients who need home oxygen. In the interest of time, I'm gonna wrap this open forum up and hand over to Mike, who's gonna lead the discussion on the summary for today, and we could take comments on Dr. Lellouche's work during that time as well.
Thanks very much. Thanks to the speakers again. And just to add on to what was just said, a lot of the discussion focus today, I think we're very focused on issues that predominantly affect high-income countries. That's where everybody in this room is from, and so I think one of the points that Francois has made in his talk is very relevant to resource variable settings, whether that's rural and less well-resourced communities in high-income countries or the majority of the world, low-income countries, where resource variability, including oxygen security, is always an issue. Here, we don't really worry about oxygen consumption and the impact of our SpO2 targets for oxygen consumption. As mostly adult physicians, and my personal bias, we also don't really worry that much as an SpO2 difference of 91 versus 93 as having an outcome difference. Clearly, there are very few trials that have succeeded in reproducibly convincing us that there is a pathological problem of having that much difference of oxygen. Zach's highlighted that in the neonatal population, it is a different story. So I think these are just two things that remind us that there are a lot of other perspectives here that are impacted by what we may make assumptions to be a simple problem or something that doesn't have impact. It may be a little bit more nuanced. Certainly, these have opened my eyes to appreciate this in different ways. So the oxygen conservation piece, and then also the issue of non-adult populations. So with that, we're going to wrap up. We have 45 minutes left. We will finish on time. And I think we'll work backwards here. There were a lot of questions that we didn't get to, and I'll do my best to try and navigate through those. This will just be open discussion. So I'm going to kick off with going back to the statistical analysis session. One of the big things that was brought up there was this idea of a hybrid design, a silver standard using a transfer standard, a reference oximeter for some of the subjects instead of the co-oximeter. Without injecting my own opinion on that, I'm just going to open the floor up. Please raise your hand if you'd like to comment on that, and I'll call on you. Ellis, I saw you had a hand up. Did you want to make a comment?
Not about that part, so go ahead, please.
That's okay. Well, Ellis, if it was about something just said, go for it, and then we can get to that. Or what was it about?
It was actually about how some of the statistical analyses are carried out, kind of in anticipation of tomorrow's discussion about best practices around pigmentation bins and whatnot. I just want to point out a couple of things about how some of these studies have been carried out.
Yeah, I think you should hold that. That's gonna be the majority of the talk. Let's see if we can get through some of the other lower hanging fruit.
Okay, sounds good.
Okay, Mike Bernstein, I see your hand was up on the issue of the transfer standard.
Yeah, I'll say right off, I don't understand the statistics, but it seems to me that in a hybrid study, the utility of the reference, the oximeter referenced part of it, depends a lot on whether the error in the reference oximeters is a precision error or a bias error. Because if it's a precision error, you can average it out, and it seems like a statistical method, which I can't really follow, but it seems that the statistical method takes care of that randomness. But if it's a pure bias or some systematic error, I don't see how you can avoid having that affect the outcome a lot.
So not to put words in Gene's mouth, because Gene will come on and talk about it. I think the objective or the target purpose method of the transfer standard, if the transfer standard is garbage, your effective sample, you'll need a whole lot of samples in order to show that effective sample size. So, there's value in using a well-behaved, known performing oximeter. I think that's just the underlying premise.
The problem is if you have something that has a fixed offset, no matter how many times you sample, you get the same problem.
Right.
You
Well,
get the
and
same value, so that doesn't.
right. And how do you get a result any better than your transfer standard? But I think if you look at the hybrid, if you look at the hybrid design, you have all three components in your base, N1. And I shouldn't be talking, Gene should be talking. But
this is Gene Canello. There's an issue with an offset, or that's already taken care of when you learn this predicted distribution. It'll account for the bias. It'll account for if there's a lot of variation in the prediction. It accounts for that too, and it won't be very useful prediction, and you won't get much mileage out of the hybrid design. But all of that is kind of built in under the hood that I haven't explained. But
Mark, we'll go to you next online. I see your hand. Oh, did you, no comment?
Yeah, no, I do. Sorry, I was just turning my mic on. Thank you. I see the really appealing part of this hybrid design was dealing with performance in children, and particularly those premature babies. And the setting is that, under the current regulatory framework, there's very little guidance on how to actually do that. And I think that this hybrid design would really be able to deal with some of that you could extend it to those additional measurements being done in the age group where obtaining arterial samples is much more challenging and often unethical.
Thanks, Mark. Just to clarify though, Gene, Paul, anybody, the proposal though is to use it instead of blood in healthy human adults, not necessarily to extend. The purpose would be time and cost saving, not the purpose of extending to other patient populations that we can't touch because of blood.
Reduce the number of arterial stinks.
Yeah. Okay, question over here.
Yeah, and just following up on Mark's question, it took us another question on my side. The question to Eugene is, do these additional subjects that we have in the silver standards testing to be different to those that have been tested in the co-oximeter study? Then the advantage is a little bit limited. Otherwise, I think if we could combine a number of measurements, especially in the clinical context and in pediatrics, doing with blood, and not waiting long to get enough blood samples, but complemented with non-invasive reference data, that could speed up the study. My impression at the moment for the adult studies is limitation is time and number of subjects and coming to the distribution. So going from 30 subjects in blood to 45 in the hybrid model might even worsen the situation we currently are in.
Thanks. Gorm, we see your hand. Go for it.
Yes. Thank you. I just wonder, I'm also a neonatologist, and I completely agree that for this patient population, it will never be possible to operate with a true gold standard. So I just wonder whether in some context perhaps, and that may also go for other patient categories, we simply have to give up the concept of a gold standard and rather go to a concept of construct validity, which means that you compare measures and you find agreement both in readings, but also in reactions to known challenges. So you sort of gradually build confidence that you are operating with a variable which behaves as you would expect. I mean, in many parts of science, this is what we have. I work with blood flow to the brain, and there is no gold standard. I mean, there's only validity comes from the fact that several methods give very similar values, and this is the way you sort of gradually build your experience basis.
Thanks, Norm. Other comments in the room, Paul?
Yeah, so it's an interesting concept of applying the hybrid design to the neonatal population. I think we need to look at it a little bit more carefully, because what we've been talking about so far is using the hybrid design in the controlled clinical laboratory. But if we apply the same paradigm to the neonatal, then we could collect some blood data, which is it's very hard to get these days in the neonatal population, and then continue with additional infants. We'd have to look at whether repeated measurements on the same subject at different times with a transfer standard would be appropriate. But the theory is collecting a certain amount of data with the co-oximetry comparison, and then going on. And the point there, you would have to have the transfer standard and the device under test. The other pulse oximeter that's under test on the infant at the same time that you drew the blood. And then you would continue without the blood samples when you can't get them anyway. And that is based on the Bayesian analysis that actually the FDA has a guidance document on. And the purpose of that is to decrease the need for a large sample size in the gold standard or the reference standard in this place. So I think it's something that's very interesting, and that it might be we ought to look at and apply to the neonatal population. What we're talking about with the hybrid design, one of the reasons for that is to decrease the number of arterial sticks. It decreases risk, and in some cases will decrease cost. And at least in our laboratory, it's very it's much easier to do a bunch of non-blood studies in the same period of time that you would be trying to do invasive arterial lines. And so I don't think that at least in our lab's paradigm, that it would cause more problems and take much more time. If we're going to collect 30 blood samples or subjects with 30 samples to 30 studies, that would take longer than doing 15 and 30. And so that's one of the purposes. It's less burdensome, at least in some paradigms. And then let me look at a couple of other things. And then let's see. Yeah, and so it is, I think, very important to start off with a transfer standard in that paradigm that has already been vetted, compared closely to a large sample size of bloods, and because the ARMS for that device should be 2 or less, which is in many well-performing pulse oximeters, it's certainly possible to attain that. And then having an averaging time that's fairly short, like 6, definitely less than 10 seconds, would be appropriate.
Thanks, Paul. Comment down there. No one go.
Yeah, so when I think of transfer standards, I think about the concept of transferring what you believe the performance of one device is one of the things that I think has to be a fundamental assumption of that is that technological differences are not there, so you can unit transfer, right? Just to simply transfer and test to say that it's correlated together assumes that you're just purely statistically trying to show something that's correlated. But theoretically, from an engineering perspective, it should be the same, right? I mean, that's what makes a transfer standard valuable, is that you have a similar technology, and now you can transfer the performance to say, hey, I can prove that the performance is the same because I know fundamentally that we have the same technology. When you do it purely on statistics and testing, now it's random. Like whether or not today you're good, then tomorrow you're not, because it's not the same technology. It's like saying, Coke is as good as Pepsi, but because I tested it to be that way, right? But you know that fundamentally they're different, and so you can't really transfer. Let's say people like Coke to like Pepsi, right? So that's where I would say that assumption is first before you get into a transfer state.
Okay, thanks very much, Bill. Over to you.
I think we've heard a lot of discussion of the limitations of a transfer standard. There are statistical problems, there are differences in device performance, on and on. And I'm going to take a bit of a contrarian view to Paul, I don't often do. But having done blood studies for pulse oximeter validation for a very long time, I am not that concerned that the tests are either time consuming, expensive, or risky. I mean, in a 1 hour period, we put an arterial line in, do a desaturation study that involves 30 samples measured with the gold standard. I don't think that the system is broken and that we really need to consider a different approach. That's my 2 cents worth.
Thanks, Phil. Just to add on to that, I mean, personal opinion, it feels like that would sort of be 1 step forward, 2 steps back. The whole discussion today has been there are imperfections in pulse oximetry. We're not entirely sure why, and now we're going to elevate it as somehow the reference for itself. I don't think we're at a place where we could do that with any certainty that won't create further error. We're at a point where we're trying to say, we know there may be some error, we need to do better. I can't see how elevating the device itself, even if it's the best of what's out there and it's validated, into that place. And the example I would give is routinely in our lab, we use multiple reference devices, what I think many people in this room would consider to be the highest end, best functioning pulse oximeters that we can find. And they do perform very well, but we have outliers that happen in all of them. And we only see that because we run co-oximetry. And we can't predict when the outlier is going to happen or which subject. We think maybe it's skin color, we think maybe it's perfusion or a combination, or maybe the weather on the day, or we just don't, they're dehydrated or they just fight till, whatever. We just don't know. And until we can predict when it will work and when it can't and who it does and who it doesn't, I can't see how elevating it to a standard level of any sort will improve pulse ox performance, which is the goal of this discussion and the standard. So I think that would be my 2 cents on that. And I agree with Phil. I do, arguably, is there some savings? I think it's marginal, and I think that, but I do think that the public health problem that we're dealing with right now is such that we can't try to save such marginal cost and run the risk of not fixing this problem. I'm very much a proponent for paying attention to cost and duration of testing because of the risk that may restrict access for many communities. If we make devices prohibitively expensive because the regulatory is such a barrier now, that's a big deal. But I don't think saving 5 to 10 minutes per study, which is I think probably what we're talking about, is going to be the difference of that particular point. Opinion, personal opinion. Paul, if you want to respond.
Well,
and then we'll go back.
Okay, I'd like to ask Gene again. I assume you're still on. If you have any comments to Michael's and
Yes.
Bill's thoughts.
I just want to make sure I understand that everybody understands the hybrid design is an accuracy study. It's got oximeter SI2 values built into it, but it's by design, you're missing some of those values on some patients, but you're still estimating accuracy. It's not that the transfer standard, silver standard, is a replacement for the co-oximeter. That would be an agreement study, which is what I had some slides on, and I was saying I didn't think that was a very viable path forward because it'd be too hard to validate a transfer standard as a surrogate, a valid surrogate for the SaO2. I don't think an agreement study is a pathway forward, but because it's not accuracy. The hybrid study does estimate accuracy. As long as those second set of patients without the SaO2 values are not, for some reason, different than the first N1 subject.
But that's a big assumption, Gene. I think that's the point. You'll never be able to prove that. And that is an inherent flaw in what you're proposing. That's my personal opinion. But I think that if you come and watch these studies being done, you will not be able to get 15 subjects in a row and another 15 subjects and have them behave in a predictable, reproducible way necessarily. At least that's not defined. I mean, and that's come up. What if you're on the same subject, different fingers? What if it's the same subject, different days? There's a lot that we don't know too much to make those types of assumptions at this point. It may be that we can predict those with better data. But I think we've all seen that the same patient, the same, same hand, different finger, different hand, different finger. I mean, there's just so many things that seem to impact this. It's very hard for me to imagine that you would control for that. Gene, what you're saying makes sense, but I think that assumption is a very big one that is too risky to take. Personal opinion, but that's my response to that. We have a comment down here, and then Jim, we can go back to you.
Yeah, so I agree. I do see though, there are populations, right? And I'm not saying a transfer standard is the right solution, but there are populations, and we talked about that today, where it's hard to get subjects. And I think in those cases where you have already verified your calibration curve, maybe it makes sense to somehow sample that population. Like we talked about preterm,
It's the best that can be done,
right,
for that population.
and subjects who so let's say you want to collect 100 subjects from a pool. If you ask 100 people, do you want an arterial line in your arm? Probably many of them would say no. But if you said, can I put 2 non-invasive sensors on you and see how they perform? I think you'd have higher agreement. And I think that's one of the things. How do we incorporate more of the population into the study? And if we can do that, and I think with a lot of UCSF and what we see from other sites is, a lot of the problem is that parents don't want. They don't want to consent to having their neonate have an arterial line, or they don't want sampling of blood. But if you could somehow still utilize, and we see a lot of studies that do that, but it's not done well because, but if we can come up with a method, I think it'd be very helpful. But maybe that's something we table until we solve the underlying issue of accuracy. Right?
Well, I would like to respond.
Yeah, let's go to Gorm online, then we'll go to Paul, and then we're going to move on to another discussion topic just to make sure that we're covering some of the outstanding issues today. Gorm, if you want to comment, then we'll go to Paul.
Yes, I mean, we have spent quite some time today to discuss the effects of skin pigment. I think Francois Lellouche's presentation of the difference between 2 oximeters in the COPD patients is quite as dramatic. That study may need to be replicated somewhere, but these patients are all over. And I would just be curious to see those 2 oximeters simultaneously recording from the same patients to substantiate that the difference was as big as they are, as represented. And if they are, that is very dramatic because it means that the calibration system we use currently may not really be valid for the patients who are most in need.
Thanks, Gorm. Paul, over to you.
Yeah, so what we're talking about is controlled clinical laboratory trials, and which is different than the neonatal. I think we should pay special attention to the neonatal aspect of this, and how the Bayesian analysis fits in with that. But you brought up a good point about recruiting in all of the population. And we do see it's tougher. And my colleague David McLeod in North Carolina had the same issue of recruiting enough deeply pigmented subjects that would be interested in having their having line flows. We're continue to expand and work on this, and I really appreciate some of the work that we've been about inclusion that we've heard today. But with the clinical controlled studies, we do not see this large bias that has been talked about, that we're talking about with the very interesting data that Dr. Schilling's group collected. As a matter of fact, in the large set of data that Gene's been working with, there's 195 subjects. 43 of them were deeply pigmented. It's 5 and 6. Most of them were fit 6. And we did not see anything close to the same bias. Show stuff, but there's no reason to take the time to do that. And so what we did see is that there was when we had Dr. Gray, used to work at the FDA, who Gene knows, do 80,000 strap set bootstrap analysis of that data. And he was able to see a highly significant difference of less than 1% between the different skin pigmentation groups. So the point is that I'm making here is that we in the controlled laboratory, we control for a lot of stuff. Local fusion, motion, and hemoglobin optimities and all kinds of stuff. And when we do that, we don't see these large changes. We see small changes, and using the hybrid analysis also showed a significant differentiation in this level. Now, I'm thinking that what we're going to end up with is we're going to improve the controlled clinical laboratory hypoxia accuracy studies. That's not a question. And I'm sure we're going to decrease the RMS from 4 to 3 at least, and maybe apply some of the statistics. But we may end up with a completely different type of study in controlled clinical laboratory, maybe, that looks at the root cause and allows us to test for this big difference that we are seeing in the real world hospitalized patient environment. I think it's what we're going to end up with is 2 separate studies. We're going to continue to have this best case essential performance in the device, measure an accurate saturation in a range of pigmentations in the laboratory when there's no confounders. And I believe we'll have another test when we figure out what the real root cause is. And we're sure counting on you guys at UCSF and ICLR study to pull this off.
Thanks, Paul. We're going to move on in the interest of time to a couple other questions. Going back to this morning's session on confounders, confounding factors in oximeter performance, factors that may not be accounted for in the current standard. There was a lot of discussion about perfusion. How should perfusion or other factors be accounted for? Open the floor for comments on that. Leo.
So yeah, since I kept bringing it up, thanks for giving me a chance to say something about it. Daniel was emailing back and forth about this question. There are ways that people use to measure perfusion that's not the pulse oximeter, right? So one of them is laser Doppler, another is laser spectral imaging. As a point of disclosure, and I'll put this on my slides tomorrow, I'm part of a company that is making a laser spectral contrast imager for postpartum hemorrhage detection, so I don't want that to seem as a reason that I'm bringing this up, but I just happen to know about it because of that issue. So I think that if perfusion index really is an important marker of accuracy of pulse oximeter, then I think it makes sense for ISO standards to include some sort of guidance as to how we validate whether a pulse oximeter is accurately measuring perfusion index. And for that purpose, I think having an alternative modality like laser Doppler or some other modality that effectively measures flow at the periphery, at the site of measurement of perfusion index, is a reasonable thing to include in the standard.
If you can package up that test method tomorrow, I'll stick it in the standard. Show me the validated evidence that it works. I will happily put it in there.
So yeah, I was looking for papers about that, so I may include that in my presentation tomorrow. But I think that what's really important is that we keep in mind that the pulse oximeter itself cannot be used to validate itself, right? And so perfusion index derived from pulse oximeter could be biased by the same issues that we're talking about right now. Having an independent measure, I think, is really important.
Thank you. Hold on one second. We got Jonas, and we'll go to you finally. Jonas online, go ahead. You're
Hello. I just want to mention that perfusion index is not a measure of accuracy of any kind. Perfusion index is strictly a measure of the size of the pulsatile signal compared to the size of the sort of the absolute size of the signal, optical signal. It's useful to determine whether or not the data are potentially of value. The data that the pulse oximeter is displaying is potentially of value, but in no way is it a measure of accuracy. And in fact, of course, because it's a measure of this fluctuating signal size, motion makes perfusion index go way high and also throws the readings off, as we all know. So perfusion index is not a measure of accuracy and shouldn't be considered a measure of accuracy. It's just another indicator of how good the data are that we're seeing on the pulse oximeter, the same way that looking at the waveform and saying, yes, that looks like a standard photoplethysmographic waveform, tells us that the data are probably more valid than if you don't
I
see
think the question, Jonas, is whether or not the perfusion index is indicative of flow reliably.
Right, and it's not a flow indicator. It's not a substitute for laser Doppler velocimetry or anything like that. It is, and you know that because of different tests that you can do to determine or to change the perfusion index that don't change the flow specifically.
So one second, go to John and then Phil and then back to you.
Yeah, it's really a measure of the signal that the pulse oximeter is getting. You know, if the camera tells you it's getting this much light, it doesn't matter how much sunlight's out. That's how much it's getting. And it's really just a confounder. It's not a measure of accuracy, although it would certainly be interesting to have an independent measure because you might learn something. And I have seen some very unusual signals. I saw in a patient in the OR, the perfusion index wasn't high, the saturation was reading low, and the PO2 was very, very high. Turns out there was a huge air gap. The real perfusion index was extremely high. Once I got it back down, everything read normally. It was only able to read something with this air gap because the perfusion index, the patient was extremely warm. So I think it would give you additional information. But most of the time, it's still going to be the most relevant thing because that's the signal the pulse oximeter is seeing, even though it's not a gold standard.
Thanks, John. Phil, do you want to say something?
I agree with John, with the exception that we don't really know what the signal represents. I mean, we are recording the perfusion index output from the oximeters, but we don't have access to the raw data. That would be a really important.
Yeah, I want to clarify. I'm not saying that perfusion index is a measure of accuracy. I'm pointing out, I'm connecting something that Phil presented earlier, which is that it looks like the data where perfusion index was low and pigment was deeply pigmented, that those were the cases that were concerning in terms of having the racial bias. So we've heard a lot of people today talk about how perfusion index is used to make clinical decisions, whether it is whatever it means, whatever it represents in terms of the data. People are looking at perfusion index. They're using the word perfusion. When a clinician sees perfusion index, they will take that to mean something. So if this group thinks that perfusion index is not a clinical index, we need to change that word because it's going to be used across the entire globe as an index of whether someone is well perfused. Just like in clinic, you would, at the bedside, you would squeeze their finger and see how perfused they are. So if we are going to use this term in a clinical way, which I think it already is being used to indicate something clinically, then we should be confident that it actually measures something clinically. And if this is an opportunity to talk about standards, then I think that it's important. If it's just a measure, and the other thing is, people are saying it's a measure of whether the signal is good or not. But if it's a measure and it's subject to some sort of bias due to skin tone, then we need to understand the source of that bias. Does it actually truly measure that the signal is good or bad in white people? And does it make an equally good measurement of whether the signal is trustworthy in Black people? And if there's a difference, then we have to understand it.
Understood. Okay, we'll go to Josh online, then Julian, then back to the room.
I'm sorry, I just have to jump in. I'm not sure I get the feeling that a lot of people here have actually read the standard, because the standard uses percent modulation as an index of pulsatile signal strength. So are you talking about completely changing the standard to remove this as an indicator of pulsatile signal strength? Because I haven't heard any discussion about that. I don't know if there's any other decent indicator that we have. I think it's probably not a bad idea to discuss whether there are better ways to quantify signal quality. But I think we have to go in kind of knowing what's the existing approach that's encoded in the standard.
Thanks, Josh. We'll go to Julian and then back to the room.
Yeah, thank you. So I think, Josh, I wanted to comment on PI, and also I think Josh hit the nail on the head. In the standard, the focus is on a signal strength or a measure of signal strength, or rather of signal amplitude. And I would support deprecating the term perfusion index, or making sure that we're very careful to note that it does not necessarily indicate perfusion. And earlier in the comments several hours ago, I posted a couple of examples, one of which is kind of almost a parlor trick, but looking at the so-called perfusion index in the hand and raising that, elevating that hand, either actively or passively. And you could see that there's an increase in PI, which is thought to be due to a change in the vascular compliance because you're improving venous drainage, for example. I don't know how well that's ever been proven, but certainly folks have tried. So the fact that one could have an increase in signal strength at the same time as a decrease in perfusion seems to be the case. And we, in this community, as a group of experts, I would recommend think about that carefully and think about the language that's being used and the terms, and make sure that we don't further obfuscate things unintentionally. That's my recommendation.
Thanks, Julian. We'll go
and then Sandy, you had asked something about the terminology or the data elements, and there was just there have been multiple comments today about the need for doing a better job to acquire the data from the devices. And so Sandy had asked me about whether we could help share information about the desired outputs from a pulse oximeter and the terminology that's used. So I don't know if that's of interest to the community, but my team at MGH is happy to help work on that with whoever's interested.
Thanks, Julian. We'll go to Norm and then over to Bob. Oh, Wim, sorry.
I agree with all of you a little bit about, with you, for example, Leo, that we might think about perfusion index as not necessarily representing perfusion. I used to work in the laser dermatology field at cosmetics, and there we would express people with a nice red blush as having a high perfusion. But if you would measure the perfusion index with remote PPG, they would have a very low signal actually. And that's, so I think there's even 3 definitions of perfusion: the blood volume fraction in cosmetics, the perfusion index in pulse oximetry, the signal strength of the modulation depth of the PPG, and the third one from flow, like laser Doppler and laser contrast imaging, that is actually measuring the entire flow. And you can give a lot of examples where they one of them is high and the other one is very low. For example, if you have a blocked outflow, a cardiovascular pressure wave will be very high, like a wave arriving in a harbor. If there's no outflow, the waves are going to be very high. The perfusion index from pulse oximetry will be high, but there's actually no actual perfusion of blood through the tissue. So in a way, it is a bit of a misnomer, I think, but I don't think we are going to be able to change it.
I think, hold on one sec. Bob, did you want to make a comment?
Just somewhat in keeping, when it comes to this term pulsatility strength, which is what it is, both of you would know about transcranial Doppler, and that's pulsatility index. It's actually a term, PI, that is on all of those medical devices. So even that acronym is in trouble. That's my point.
Yeah, and that's right. We're talking about percent modulation. The thing that the pulse oximeter looks at is not flow, it's how big the modulation is, and that's what we should be talking about. Perfusion index, it is, now that you mention it, it's a misnomer. I think we should talk about percent modulation. And the other piece to this is that pulse oximetry has a problem because it's got two wavelengths. Red is just attenuated like crazy in many ways. Infrared just blasts through just about everything. And I think, and maybe Jonas can weigh in on this, that that the way we're measuring percent mod, maybe we should call it instead of perfusion index, is pretty robust with the IR measurement that is being made with now. And so I think that's the direction we should go. Thanks.
I wanted to say that I want us to keep in mind how this is being used by bedside clinicians. What do we want a nurse or a doctor to do when they see a PI, whatever we decide to call it? Most of the cases, it's supposed to help them decide, do I keep the sensor here? Do I move the sensor or get a different sensor? Or do I believe the saturation number that's delivered? That's one piece that it's trying to deliver. The other is, I think there is a future for it in some place, especially when you look at it in a trending sense, not an absolute value, but as in a trend, to say whether or not, wherever the sensor is located, is that area being perfused? Is there some type of pulsatile flow to that tissue? Whether or not that's an absolute value that can be recorded, or whether or not that's trending data that's valuable, when we name it, when we're thinking about this and making changes to what the requirements are, keep in mind that's what we're trying to deliver.
Thanks very much. Other comments on the topic? Oh,
yeah, I just wanted to comment about how we use perfusion index, and it might be better called percent modulation. I think that's a good suggestion. But we rely on it clinically a lot, not only to determine whether the sensor might be in the wrong place, but to assess a lot of things about our patient. And one thing that we look at and pay a lot of attention to in surgery is the variation in the perfusion index, or pulse variability index. That's a very sensitive monitor and very important monitor for us in the context of things like shock, blood loss, hypovolemia, changing conditions during surgery. So clinically, these are indices that are being used, and they are terribly important. I think what our job is to make sure that the way pulse oximeter information is presented to clinicians are optimally useful, and we don't create misleading situations where we're misinterpreting things by naming them the wrong thing. I think percent modulation probably is a better way to do it. It's not blood.
Thanks, Phil. Julian made a comment. Pulsatile signal amplitude may be better than perfusion, may be better than modulate, like more. It has some. You can understand somewhat what it is. Yeah, a little bit more intuitive. But we're going to put a pin in the perfusion discussion for now. We'll come back to it tomorrow. In the last few minutes here, another thing that came up was the issue of what is the relevant clinical range, and do we need to test all the way down to 70%? And that also touches on the issue of efficiency and cost and time savings and things like that as well. So thoughts on, do the controlled desaturation studies need to go down to 70? Could 80 to 100 be adequate if that covers the clinical range of interest? And thoughts, comments?
As a
Can you also mix in
clinician-
there what you think a clinically significant difference in saturation is, please?
Depends on the patient.
Yeah, I mean,
If you-
if a monitor says 70 or 78 or 82%, like I am not gonna hold back on intervening. So I would argue that any of those numbers are gonna demand your attention and an intervention to rescue your patient. So I personally don't find those numbers particularly relevant.
But if you have a child with a single ventricle and an ongoing chronic shunt, knowing if that shunt needs revision may take you between 75 and 80. And you need that accuracy in that range.
Point taken. I am an adult doctor. I deal with very little congenital heart disease, but I would argue that my practice is representative of most patients that are using these devices, and perhaps there are special cases that should have dedicated special equipment, and we should be kind of speaking to the 95% of the applications.
Bob, let the engineer challenge you for just a moment. Sorry for taking prerogative. If I'm looking at trend and you're at 75 or 80, you don't really care, but you're looking to see that it goes up. It's not the absolute value that's concerning you, it's that it's going up.
Yeah.
I was going to say you actually modify your therapy based upon it to get the child stabilized in order to get them to surgery if need be. So there is a range there that you would like that the precision still at 80 or 75.
We're gonna go to Bill Williamson online after that, Jim. Bill, over to you.
Yeah, thank you,
online.
Mike. It's Wilson's last name.
Oh, I'm sorry.
Yeah, no problem.
Sorry.
No, I think today is really more of a data gathering and idea, ideation day, right? And tomorrow's gonna hopefully be a little more summing up. So I hope our minds aren't turned off too much in terms of what we can talk about. But it just seems to me that if we focus too much on it, we're now off the transfer standard. I think maybe that's a good idea. But if we also talk about change in definition of perfusion index, we're starting to talk about things that that's like those are big lifts, but what can really affect improving the ability to measure individuals with dark skin would be things like decreasing the ARMS overall, increasing the number of individuals in ISO studies, increase the number and percentage of dark-skinned individuals, and then how can we quantify that? And so if we focus on what we can do, and really, now hopefully, we're going to talk about this more tomorrow, but I think that's important. And I apologize that you did ask to change the discussion point just a little bit, just after I'd raised my hand, and the question was about the DSAT, and I'll just vote on that, which is, I think we need to look at the entire range. It's important that we know that we can depend on the pulse oximeters when we do have individuals that are sick and they're in that range for whatever reason.
Thanks very much.
Yeah.
Sorry about the name.
Yeah, thank you, no problem.
Jim, over to you.
I guess that looking at a lot of these devices, I guess I'm concerned about the use cases. And in Burgundy, one of the largest use cases is spot checking, triage, screening, with the cost of and the performance potentially of trying to get a pulse oximeter to work over this other range, let's say 80 to 70%, that is useful in certain settings, but typically would never be used in a lot of other settings. So I think, and I'm not obviously a device guy, but when we're talking about decreasing the ARMS, but we don't want to increase the cost, then I think it is important to look at the range, because you're trying to curve fit over a range and in between 80 and 70 where that variation becomes increases and will increase your ARMS is going to be more difficult to remove. So if you reduce that range, I think you're going to get, because it's a curve fit, it's an empirical calibration, right? That you're going to be able to potentially get better readings. I don't know if you're not trying to fit and minimize your ARMS down to 70%. So I can't answer that. I'm not a device manufacturer, but I think it's something to consider when you're talking about a combination of reducing your ARMS without increasing the cost and the type of use cases that a lot of these pulse oximeters are used.
Thanks very much. Phil, and then we're going to wrap up.
Yeah, with respect to the range of saturations that we study, I would strongly advocate keeping the less than 80% range, because I think it's had a very beneficial effect on the overall quality of pulse oximetry. To sort of force the technology to work well in that lower range ensures that it is probably more accurate at the higher range. We've heard again and again today that small differences in performance do make a clinical difference. So we're talking, if we accept that, then degrading the standard to make it less good seems to me like a bad idea.
Thanks, Phil. All right, well, we're coming to the end of our first day. It's been a long day. Thanks, everybody, especially those who are a few time zones ahead. But we're going to go ahead and wrap up. To sum a few things up, so I'm going to give everybody a little bit of homework. Tomorrow at the end of the session, I want to come back to some of these things because I don't think we have resolution. There's also going to be additional comments and questions tomorrow that we're going to want to discuss. But if you could start thinking and making a list of your top 3 changes that you would recommend to the ISO standard, and just start thinking about those. At the conclusion of tomorrow, we'll go round robin and everybody will state them very succinctly, in 30 seconds or less. But if you could start thinking about that list based on the discussion today and tomorrow, please start building that. This afternoon, we talked a bit about what to do with PI, how do we account for it. To Bill Wilson's point, a lot of the focus is this issue of skin quantification, skin color, how do we do better there? Tomorrow, we're going to really dedicate pretty much the whole day to that, and that is, I think, the focus, and your point is well taken, but there are these other issues, and I think the fact that we are seeing potentially this signal of PI and skin, what do we do with that is where that's coming from, and I'm just not sure we know, but so keep that on your radar, what to do with PI. The transfer standard, we'll continue those conversations, but consider that in your recommendations for tomorrow. And then the SpO2 range issue, just as 3 big ones that have come up today. Tomorrow, there's going to be a dedicated session about how we can use the standard, leverage it to better communicate, whether that's the package insert or how the monitor displays information. I think a lot of the things that were discussed today are relevant to that. There's a 1 hour, it's just going to be discussion tomorrow about that topic. So please separately keep notes and thoughts about that, because I think based on comments that we have in the chat and the discussion, that could really be a big, that could be an area where we could make some big progress. So with that, we're going to conclude. Thank you to all of our moderators, our speakers for today. Thanks to everybody who traveled here. Tomorrow is going to be in the same building for those of you who are here in person. For those of you who are online, it will be the same link. Tomorrow we start at 9 a.m. Pacific time. We'll have 30 minutes of check-in. Of note for in-person participants, you'll need to check in with security because we'll be through a clearance area tomorrow. You'll go up the elevators here, but they'll need to buzz you in. So make sure to get a badge and do the online screening that was in the email that you got. And then tomorrow morning, we're going to be talking about skin pigment quantification and ways that we can improve that. So look forward to a rich discussion. And we will start off the morning with very brief introductions for those who are in this room. Just your name, where you're from, why you're here. 15 seconds. We don't want to take an hour of intros, but sorry we didn't get a chance to do that when we started this morning just because of the timing. Thanks very much. Everybody have a good evening. We'll see you tomorrow.